So we'll talk a little bit about web, see if you guys can stay awake. All right, so in full disclosure, I'm a proctor for web. That's the device. You've seen it in the lab. It's important when you get any new device. This is from one of my former fellows. I was all excited about putting in my first device, and he's like, "Oh no, you've been caught in the web." And that whole thing of, if you get a new toy, you think everything's going to be good with that device. So you have to be a little bit careful. There's the technology adoption curve. There's people that want to be early adopters and innovate, and then the majority kind of catch on. And then there's people that still believe that clipping basilar aneurysms is normal. But eventually most people end up doing the right thing. Then you have to keep in mind the hype cycle. So that kind of goes back to what I was saying, that when the new device comes in, everyone's like, oh, every case should be webbed, or every case should be pipelined. We kind of saw that when flow diverters came out. And then it kind of goes down a bit, and it's like, oh, now I've seen a whole bunch of complications with that device, I don't want to touch it. And then it kind of gets back to where it probably should be. And so it's important to have some insight into your own behavior and your own biases. You got to know when you're crazy. So there's an unmet clinical need. We talked about bifurcation aneurysms, and that's really what we're focusing on, these saccular bifurcation aneurysms. Aneurysms with a wide neck and a dome-to-neck ratio greater than 1 and less than 2. We have a range of devices. You guys use the Pulse Rider device in the lab, and hopefully got a bit of a feel for that. We've got stents. You can do Y stents. You can put in a single stent and then shoulder the stent up into the other branch to kind of create more of a shelf. You can do P1 stents. There's all sorts of different options, but they all require dual antiplatelet therapy. So that's kind of what web is invented for. There's two different shapes. There's the SLS and the SL shape. So there's these kind of a barrel shape, and then there's more of a cube or rectangular shape. That's the SL, and then the SLS is more kind of spherical in shape. And the important thing with the web is when you put it in, you have to have radial compression. So when you put in the device, you want it to be kind of pushing against the walls of the aneurysm. If it's perfectly sized to the aneurysm, then it'll be loose. And if it's loose, then you can get filling around the web, and that's a big problem. So if we look at the history of web, back in 2010, the dual layer device was brought out, and then it kind of evolved from 2010 to 2017. Now in Europe, there is a delivery system using the 017 system. We're still on the 021. So as usual, we're kind of way behind. And when I was back in New Zealand 5 years ago, they asked me, how many webs have you put in? And I was like, what's a web? And that's like other places in the world, like Europe and Turkey and Brazil and these other places, they can really get these devices a lot sooner than we do in the US with the FDA process. So we're finally there. I did see a good slide yesterday, the one and done, which was changed to one and done until I get the next one that's the right size put in. So we're still learning to get the right sizes. That's the most tricky part with web, and I'll talk about that shortly. But the concept is that you put one device in, and that's all you need, plus or minus a stent. So less time getting irradiated. You seal off the neck of the aneurysm with the device, and how it works. You can see on the bottom there, it's a very, very high metal coverage, about 60%. With basically 100% at the center of the device. And then you get this endothelialization or scar forming along the base of the web, and then that scars off. There's a microbraid technology, and as I said, there's a really high metal coverage at the neck of the aneurysm. It's quite visible. Hopefully you all got a chance to look under the fluoroscopy, how easy it was to see. The original device was not as visible as that. So we're lucky now we can actually see it. It's not just kind of using the force, thinking it's in there somewhere. So the device, there's this little animation. If only everything in medicine was as easy as the manufacturer's animations. So you've seen the device, you've played with it in your hands. We measure the device, and we want to make sure when the device goes in, it gets constrained. So we oversize the width of the device, and we shorten the length, so that when it goes in, it's squeezing against the walls of the aneurysm. That makes sense? So if you've got a 4 millimeter aneurysm, you probably want a 5 millimeter width device, so it's squeezing against the outside. Otherwise, if it's loosey-goosey in there, it'll move around. All right. So it's approved for bifurcation aneurysms, 3 to 10 millimeters in size. I'm not going to belabor some of the data because I want to get to some videos. But there's been a number of trials done around the world, with the most significant of which was the Webbit study, just recently released in Journal of Neurointerventional Surgery, with Dr. Arthur being the principal primary author on that. 27 centers, 150 patients, single arm, ruptured and unruptured aneurysms, 3 to 10 millimeters in diameter, with core lab adjudicated outcomes, and that's important. Obviously, if you look at your own outcomes, they're way better than when the core lab looks at them. So mostly females, small number of ruptured cases, and the locations, ACOM, basilar apex, a few ICAs, and then MCAs. The primary endpoint was complete occlusion, and the secondary endpoint was adequate occlusion, approaching 85%, which is very similar to stent-assisted coiling, which I'll show you shortly. So what is complete obliteration with the web? So because of the way the web is designed, hopefully all of you got to see it, there's that little stippling or indent in the bottom of the web, so it's normal to have some contrast on the inferior aspect there. And then there's the little detachment handle that comes down. That's totally normal. Having a residual neck is considered adequate occlusion. So if you get that kind of hat shape at the neck, that's believed to be adequate occlusion. It's not thought that aneurysms are going to rupture from that residual. And then the residual aneurysm, if you have flow going around the web device, that's a problem. And we'll talk about some of the techniques that you can use to fix that. So this is an example of a good occlusion where you've got adequate obliteration of the aneurysm at 1 year follow-up. This is an example of not so good obliteration where there's actually filling around the edge of the web. And there's some strategies that are used for retreatment, and we'll talk about those in a minute. The complication rate is extremely low for web. 0.67% had a major stroke or death, so that's really, really low. No deaths through 365, and if you're going to have a problem, it was at the time of the procedure. So 85% had adequate occlusion at 12 months. Complete obliteration was 55%, so depending on which side of the coin you are, you can say, well, this is terrible, it's 55% complete obliteration compared to clipping, that's really low. But if you look at adequate obliteration, it's actually really high when you compare it to coiling, for example. So for occlusion with coiling or stent coiling, it's about 30 to 62%. So we like to think that every aneurysm we coil gets 100% obliterated. That's not actually true if you look at the data. Cost effectiveness, assuming you don't need to have a couple of goes with the sizing. Web can be very effective, particularly in bigger aneurysms when you tend to be using more coils. So that's a good thing. At the smaller end, it's a bit of a wash depending on which coils you're using. X-rays are bad. You never know what you'll find when you take an X-ray. And with the Web device, we found that our procedure time in general is significantly shorter than stent-assisted coiling, and that makes obvious sense. When you see some of the videos, you'll see why. When the device is going in, it's pretty quick. Retreatment in the Webbit trial, 8 patients were retreated, 1 with coils, 4 with stent coiling, 3 with flow diversion. Interestingly, none crossed over to clip. So those that have had to clip the Web device, apparently it's easier than clipping a previously coiled aneurysm because the Web will collapse because obviously the aneurysm is still filling. Whereas with coils, as we saw before, it's a lot harder to get the clip to clamp down when there's coils in the way. So the retreatment rate is similar to other endovascular studies, 21 to 50.8% in other studies. Overall retreatment rate, 9.8%. In terms of antiplatelet medications, you don't have to have antiplatelet medications with Web, so particularly in ruptured cases, most people were not using that. For elective cases, it's kind of dealer's choice. We keep everyone on dual antiplatelet therapy at the start of the procedure, preoperatively, in case we need to put in a stent. We'll talk about indications for stenting. Case selection, case planning, and dual antiplatelet therapy, we'll get into a little bit of that, and then we'll show you some videos. Case selection, easier cases, straight vessel, longer aspect ratio, medium-sized aneurysms. Basilar tip's probably easier than MCA and ACOM, and that's just because the basilar tip tends to have a straight shot at the aneurysm. The difficult ones are when the neck comes off at a different angle compared to the parent vessel. So your parent vessel's like this, aneurysm's like that. That's much more difficult. Angled middle cerebrals, like in that cartoon. And shallow aneurysms, because as you guys saw, there's that spear, the spear of death, as I call it. When you're putting out that initial spear, it's pretty sharp, and you can perforate an aneurysm with that. So if the aneurysm is very shallow, it's kind of risky. If it's nice and long or large, you've got way more wiggle room for that stiff part when it comes out. Once you get more of the device out, then it becomes very soft. But there's that initial few millimeters where it's a pretty stiff device. So it's important to remember that the VIA is really, it's quite a stiff catheter, and it has to be by necessity, because when you pull the device back in, if you're redeploying it or pulling it back in to redeploy, it has to be stiff enough to take that shelf from the Web, compared to a coil. Coiling catheters tend to be much more less stiff, because they don't need that stiffness at the tip, because you're only having pulling coils or stents in. So out of necessity, it has to be quite a stiff delivery system. Have to be careful when you're going around the A1 on ACOM aneurysms, because the device is quite stiff. When it comes around, it can kind of load the system, and it can lunge forward, which can perforate the ACOM aneurysms. It's important to plan if you want to be successful. If you are not successful in your planning, it's going to be a bad day, and you're going to get very angry, like this guy. Antiplatelet therapy, we tend to keep everyone on dual antiplatelet therapy up front. If there's no impingement on the branch vessels, then I will stop the Plavix and keep the patient on aspirin. If there's any encroachment on the on the branch vessels, then I'll tend to keep patients on Plavix, and certainly if you had to put in a stent, I'd put them on Plavix. Stenting, indications for stenting, 50% residual stenosis of the branch vessels. So if you have a slow flow, that's obvious, you have to put in a stent, or if there's 50% stenosis, you should put in a stent. Some people have advocated using balloon reconstruction to help kind of guide where the Web is going. That's a kind of a more advanced technique. And salvage situations for webs that go in the wrong place, using a loop snare to grab the handle of the deployed Web. I've seen that. That was an impressive save. Undetached devices, we'll talk about that in a second. We have seen the device kind of flip or rotate in the setting of an undersized device. And then if there is an endo leak around the device, then putting coils into that space to kill the dead space is kind of a salvage. Once the web's detached, you obviously can't really get it back. Non-detachments, if you dry the system, that will usually fix the problem. Sometimes you can get what we call a sticky detachment, where the detachment zone is basically kind of stuck. Usually if you torque the wire a little bit, get up there with the via, it'll kind of click it off. But that can be a kind of a moment of what's happening. This is not good. This is really not good. But usually it does sort itself out. Imaging and sizing, it's important to measure the size of the part of the aneurysm to be treated, and I'll explain what that means. We basically ignore the Murphy's excrescence. If you have an aneurysm that's shaped like this with a big horn off the side, you don't put the web up into that area. You basically treat the square at the base and ignore any Murphy's excrescences, so it's important to measure to fit that. It's important when you are deploying the device that you deploy the device exactly where in the aneurysm you've measured. And what I mean by that is if you have measured the box at the bottom of the aneurysm to be 4 millimeters in height and you're using a 5 millimeter device, 4 millimeters in width and using a 5 millimeter width device, you don't want to start deploying it either too high or too low. If you deploy it too low, it's going to fall down into the parent vessel. If you deploy it too high, it's going to be halfway up the aneurysm. So you have to figure out where you're measuring and put the device there. Does that make sense? It'll make sense when you see the videos. We measure the device in the AP and lateral on X-ray after placement. And what we want to know is that the device is under compression. So if the device has a 5 millimeter width, when we measure it in AP and lateral, it should be less than 5, meaning it's getting compressed. Does that make sense? If it's 5, it's loose. It's not getting compressed by the aneurysm wall. So if there's say an 8 millimeter width aneurysm and you put in a 9 millimeter width device, when you measure it, if it's 9 millimeters, it's not getting compressed. Does that make sense? This is really important because otherwise you're going to get an endo leak. Dyna CT is very important to look for branch occlusions. So this is the sizing chart. I'm sure all of you guys took a look at that when you were putting in the devices in the lab. So you want to take your width, your average height, your average width, and then you basically follow along the card, and that tells you probably what device you'll use. But there's a little bit of experience that comes into it when you kind of see the shape of the aneurysm in three-dimensional space and how it might deploy. Suboptimal placement, when you're detaching the device, you don't want the via to be under tension, so you don't want it to be loading. If that happens, the whole thing can kind of shoot forward when you detach it. If you have it pulled back too far, the same thing can happen where the web will sort of spring back into position, so you just want it completely neutral. If the device is too small, it will either bounce around in the aneurysm or you can use it to kind of cork the neck of the aneurysm. But if you're going to do that and leave lots of dome behind, you might want to put some coils in the top because otherwise what can happen is it can just piston in and then it's not going to occlude the aneurysm. You can replace with a larger device if you put a smaller one in. Obviously, if you detached it, then you're going to have to do something else. The resheathing process, did all of you guys resheath the web? It feels kind of weird, right? So you have to really kind of clunk it back into the via. And you'll see on some of the videos that I'll show next that that can be a little bit nerve-wracking. And if it's greater than 50% stenosis of a branch vessel, will be ready to stent. So this is a case, this is a 54-year-old with a broad-necked ACOM aneurysm. So obviously this is a web torque. It's going to get a web, but who would treat this with clipping? Assuming web wasn't available, who would treat this with clipping? 54 years old, healthy. Yeah. A year ago I probably would have clipped this. What about stent coil? Who would stent coil? Okay, couple. Yep. So this is the sort of case that we've spent 2 days talking about clipping and coiling, and this is a case that would now be often treated with web. So it's kind of interesting how the technology can change very rapidly. So it's important to kind of keep up with these changes. Won't delve down too deep into the systems that we use. And this is the device going in, and I've got no laser. Okay, so what we're looking at is, you can see the device here. So we're just unsheathing it now, and you can see it's kind of getting I call it a genie. It's like a genie shape, and it's starting to open now. And you can see that it's now it's very soft. So we've got rid of that spear part, and we're deploying the device, and it still looks nothing like the web does once it's fully deployed, right? It's kind of like this genie shape, and then all of a sudden, it just goes pop, boop, boom, and that's the end of the case. So it's a little bit disconcerting the first few times you see that, because you go from having this kind of weird shape thing, and then at the very last second it just completely deploys, and it's either good or it's bad. So it takes a little bit of getting used to. We'll do a run, and you can see the contrast stasis in the aneurysm. So we're happy with that result. And then before we detach it, we want to make sure that our branches look good, and they look good. And then we take the strain out of the system. There's a millimeter on the end of the microcatheter that you can't see, so you have to pull the microcatheter back a little bit. I think Lisa probably went over that in detail in the lab, and then you can detach it, and it looks something like that. So that was a nice result. That was our first web case, actually, and it went pretty well. Patient did well from that. This is case 2, so this is a basilar aneurysm. And I think the important thing to look at here, it's easier to see on the native on this back panel here. So we're looking here. This is the device coming up. And initially you have that spear, and that spear is kind of dancing with the back of the aneurysm there, which makes you a little bit nervous. So we've pushed the spear out, and now we're unsheathing until we get that kind of soft genie shape. And now we've got enough device out. That's kind of it's a soft device now. So we can be more aggressive about pushing this thing around in the aneurysm. It's much softer. And we can push it up to where we size the device to. And again, you can see as you're pushing out device, it still looks like it's not going to be the right shape or size or whatever. And then at the very end, it just kind of plops into position. Boom. There you go. Yep. So in this one, we were a little bit low. So initially we went to pull it back in. You can see the whole basilar system just kind of moved. And that's when everyone's sphincter tone kind of hit max. So we decided to push that device up to kind of plug the neck of the aneurysm and push off those two P1s. He had a good PCOM on the right side, and so I took that into account when we did this run here. You can see on the left P1, we're quite clearly clear of the, we'll roll through it in a second here. We're clear of that vessel. On the right side, there was maybe about 50% stenosis. But we didn't need to stent because he has a good P1 on the other side. So even if I'd completely occluded it, even if I'd fallen all the way down and occluded that right P1, I wouldn't have put a stent in, right? If he didn't have a PCOM, that's a completely different story. Then I would have had to stent it. So when we did the 3D, this is what it looked like, and you can see on the angio there, again, the left P1 is good. We got maybe 10% stenosis there, which is fine. Don't have to worry about that at all. On the right side, it's about 50%. We didn't see any flow limitation, and again, he had a good PCOM, so we just left it. And that patient's done well. This is a third case. This is a 45-year-old So again, kind of an ugly aneurysm. There's a Murphy's excrescence there, kind of a boot-shaped aneurysm. Again, this is a web talk, so you know what's going to happen next. But if I saw that case a year ago in a 45-year-old, I probably would have strongly considered clipping that case. This is a slightly more challenging web case because it's quite stumpy. So we have to remember we want to put the web into the part of the aneurysm we want to treat. So the web is not going to go all the way up into that boot. It's not going to go into the toe of the boot. We're just going to kind of treat the ankle part of this aneurysm, of this boot-shaped aneurysm. We'll see that on the video, and it kind of makes a bit more sense. So you want to ignore the Murphy's excrescence and treat the part of the aneurysm you want to treat. So again, that spear, we have a very short landing zone, and I use the Murphy's excrescence to give myself a little bit more space. You can see that there. And then once a bit more device is out, the web will tend to center itself, and you'll see it's kind of, we're unsheathing here, we're not pushing any device out. And then once it centers at the very end, the whole thing just clunks down into the middle. So you'll see here in a second here, boom. See how it kind of clunked down into the middle? And there's no web device up in the Murphy's excrescence. It's all come down. And so again, this is a very broad-based MCA aneurysm that I typically would have clipped, but now you can see really good contrast stasis there with a reconstruction that if we'd used a clip, we would have been very happy with that. So when we do the Dyna CT, you can get pictures like this, which show a nice reconstruction. The handle or detachment zone coming down into the parent vessel like that, that's normal. The first 10 times you see it, it's really abnormal, but that's what you want. You don't get any thrombotic complications from having that handle dipping down into the branch part of the vessel. This is a 72-year-old who had bilateral MCA aneurysms. This is the one that we'll show the video on. The week before, I had treated her pretty irregular-shaped MCA on the other side. You can see the web kind of took on a funky shape on that one, but it ended up including the aneurysm pretty nicely. So we did a similar setup to before, and again, mostly unsheathing because this is a pretty shallow aneurysm. So we're mostly unsheathing here. We have that spear of death. We do not want to be pushing the device out at that point. Now we're starting to get that kind of genie shape. It's much, much safer to advance the device out by pushing wire or rather than having to unsheath. So now it's mostly pushing wire or pushing the system together as one. And then again, all of a sudden, once you get to the end, it just goes boom, done. And that device is out. We'll do a run, see where we're at. I think. Yep. So this is, I can see by the fluoro marker, there's about a 20-minute case. We got a nice result there with, I think, a good contrast stasis and a nice neck coverage. A 20-minute case in an elderly patient, it's kind of hard to argue that opening their head both sides is going to be good. And then one last case. So this is an MCA aneurysm, very broad base. In my hands, this is a very difficult stent coiling case. I think you have to get a stent out that very small inferior M2, and even getting a stent out of that would be very difficult. Putting a stent into that superior division is not really going to help you protect the neck completely. So in my hands, this is a clip case a year ago. So these are the working projections. Again, we get the veer into the aneurysm and then put a little bit of the spear out and then it's mostly unsheathing. You can see how that spear is getting really close to that Murphy's excrescence right there. And then it's mostly unsheathing. Now it's soft, we can be a little bit more aggressive. It's just that first few millimeters you have to be super careful. And then we're just pushing that last bit of the device out, and then it's going to go pop, pop. Okay. And then when we do a run, so we're trying to keep that inferior division M2 alive, which is kind of the tricky part. We're checking, we're measuring, making sure it's constrained, and you can see there's good contrast stasis there, and both of our M2s are open. This was an 11-minute case. So again, when you compare that to surgery in an older patient, it's a very elegant treatment when it works smoothly, and they always go smoothly. So take-home points, just to conclude, case selection is key. You want to make sure that you've got that nice straight vessel going into the aneurysm without the angles. Those are certainly more tricky. Size selection, I think with experience that it kind of improves, but getting the right size, knowing which part of the aneurysm you're going to treat, that's kind of a really different concept to what we're used to. Normally the coils kind of go everywhere into every compartment. This is a completely different game plan. The VIA is a really stiff catheter. All of you guys felt that when you're going up with the microsystems in the lab. It's completely different to a normal coiling catheter. There's a learning curve, and the easy part of the learning curve is a straight shot parent vessel, larger aneurysm with a long aspect ratio, and the opposite of that is more difficult. So I'll stop there and take any questions. It's been a long day, but you've all done well, and you're still awake. That's always good. So I'll stop there and take any questions. Thanks. Yep, at the back.
So you said the VIA is a stiff catheter. Is it a feature that you use for this device, or are there other alternatives?
The first thing is the Europeans can deliver the smaller system through an 017, not an 021. So that's less stiff. But the reason it has to be stiff is if you think about that square shelf once the device is out, if you have a regular, very soft tip microcatheter, which they're designed that way by design, deliberately, if you try and pull the web back into that, they can accordion and they can stretch. So people have done it. It's not recommended by the manufacturer, and I have not tried that. I don't need to get that T-shirt. If someone else says it's bad, that's all I need to hear. So yeah, the microcatheters are just not stiff enough to handle that kind of pulling it back in. Once it's in, it's not too bad, but it's just that initial pulling it back in. Question here?
Okay. When we choose web over the clip ligation in MCA aneurysm?
That's a great question. So depending which fellow is on which service, if they're on the clipping service, they want to clip everything. And if they're on the web team, they want to web everything. No, in all seriousness, it's I think it comes down to this slide, actually. So if you've got a nice straight vessel with a nice aneurysm coming straight off the parent vessel, you don't have too tortuous anatomy. Tortuous anatomy is tough because the device is quite stiff. At least the iteration that we have, it's quite stiff. Very short aneurysms, it's a little bit more risky, I think. And aneurysms where the angle of the aneurysm is different to the angle of the parent vessel. So if you have parent vessel here, aneurysm coming off like that, that's not great because you have to deploy the device in the parent vessel and then roll it into the aneurysm. You can do that. People have done that in Europe who've done hundreds of these, but it's a little scary to watch. So I think clipping in those cases, at least in my hands, is safer. Yeah, I mean, Basler, it's fantastic because it's a straight vessel. You know, if the microcatheter comes out, it's really easy to get back in there most of the time. Some of these ones where the ACOMs or MCAs, if you lose access in a very short vessel, it's really painful because you have to pull the web back in, then go back in again. So I don't think we know the answer to that, but I would say we're still going to clip very small ruptured blister-type aneurysms of the MCA 2-3 millimeters. Those are not great web cases because we don't have the very small devices here yet. Very young patients, we don't have 20-year follow-up on web. But I think that question we're going to know better in about probably 12 to 24 months because we're in that adoption part of the curve where there's a lot of people that are very enthusiastic about web, and we're going to see this rise, and then it will go down, and then it will probably end up where it should be. So I think we'll probably get a better idea of that in about a year's time.
I just want to mention that Dr. Monteith is really good at this, but putting a web in is just as stressful as putting an anchor. He makes it seem as if it's really easy and all these cases work really well, but it's extremely just as equally stressful putting on these things. So in the end, deal with comes to you because sometimes clipping an MCA aneurysm is just your thing. So.
Yeah, I think, I've learned a lot from proctoring cases around the country and from everyone that's done web, that you learn from everyone, that's done a lot of these cases, and there's a lot of new it's very much like when pipeline first came out. There was sort of pipeline fever people talked about, but there's a big learning curve kind of nationally and internationally where people learned kind of little things that made a big difference, and I think web is kind of similar to that. Yep.
Does the bottom of the web system allows blood flow into it? And if so, how does the occlusion work?
So initially it does, but over time it endothelializes. So you get a scar forming over several months. Over how long?
How long?
Well, so in the dog studies, they looked at 3 months. We're going to have to wait for autopsy studies to see what it is in humans, but most of the time it's gone at 6 months. And sometimes we've had cases where you'll do the run and there's basically no filling. There's that much flow diversion. If you take a web and you get, food coloring or colored water and you put it in there and you hold it up, sometimes the water doesn't come out. There's that much surface tension in the device. So, some of these, particularly ruptured cases, the Europeans, in WebIT there was only a handful of ruptured cases, but in the European studies, a lot of ruptured cases were done. And as you know, people that have ruptured are very prothrombotic. So they're not on dual antiplatelet therapy, they're prothrombotic, they've just bled, and people will angio them at the end of the case, there's no filling. So that's the flow diverting effect, but the scar probably takes several months. All right. Well, I think that just about wraps it up for another year. So on behalf of everyone at SSF, we appreciate you guys all coming from all over the world. And hopefully you guys learned something. Want to put a special shout out to our faculty, particularly our guest faculty who've traveled a long way around the country. Dr. Deschmok had to catch a plane, but Dr. Dumont, again, coming from Tulane University, it's a long way to travel. Just to teach you guys. He's not paid to do that. It's just out of the goodness of his heart. So we really appreciate that. And again, thank you to our sponsors. You met most of them in the lab who make these things happen. If it wasn't for industry, we wouldn't be able to do these things. So if there's not any other questions, that's it. We're done. All right.